Hello, my name's Mervyn Singer. I'm delighted to talk to you today about hyperchloremia, the conflict of interest. As you see, Singer is very close to Ringer, and there's another connection. Ringer was Professor of Medicine at University College London Hospitals, and I'm Professor of Intensive Care at University College London Hospital, so clearly heavily conflicted. However, as you'll find out from my talk, perhaps not so much. So let's just quickly refresh our minds about balanced and unbalanced salt solutions. So balanced means similar to plasma, unbalanced isn't. So saline is an unbalanced solution. It has a high sodium content, a high chloride content, and the osmolality is fairly normal to plasma. However, the contents of balanced solutions still have a high degree of chloride apart from plasmolite, but they actually have a low osmolality. And there's a lot of controversy about balanced and unbalanced solutions. I sit on the fence. There is an association between hyperchloremia and worse renal outcomes, but is this an epiphenomenon or cause and effect? And as I'll show you briefly, prospective studies of balanced versus unbalanced, the high chloride fluids, show no difference in mortality or length of stay, and a statistically significant, but actually clinically a very modest increase in the need for renal replacement therapy. And I would argue this whole debate is rather pointless if you monitor chloride levels in the blood and adjust fluid accordingly. So there am I sitting on the fence. Just a quick revision of physiology, salt handling. So we normally take in about 3 to 5 grams of salt a day, and about a third of that weight is sodium and 2/3 is chloride. 0.9% saline, normal saline means 0.9 grams in 100 mils. So in other words, 9 grams of salt per litre. So this is 2 to 3 times our normal body intake is in 1 litre of saline. So if we give 4 litres of saline as resuscitation to a patient, we're giving 36 grams of salt. To put that into sort of equatable terms, a packet of crisps contains 0.4 grams of salt. So 4 litres of saline gives 90 packets of crisps. That's a hell of a lot of crisps for 4 litres of saline. What about chloride? So chloride is handled in 2 ways. Absorption is controlled by the guts. If you have lots of salt, some of the absorption is regulated by gut receptors, and there's excretion, 90% through the kidney, others through sweat and so forth. And we generally take in and excrete about 140 millimoles of salt per day. So we were not designed by evolution, God, whoever, to have lots and lots of saline given to us rapidly and intravenously. So renal clearance may not cope, especially if those kidneys aren't working very well. And it may be chronic renal dysfunction, acute or acute on chronic. So because of that buildup of chloride, there's a shift in anions and cations. So the patient develops a hyperchloremic acidosis. The doctor gets worried, they're more acidotic, and then they often get more saline because they don't realize the problem is chloride overdose. So my question is hyperchloremia a cause or an effect of renal failure? So when you look at animal models given lots of chloride, there's apparently, it's been described that you get vasoconstriction of the afferent arteriole, which can lead to a reduction in renal blood flow and cortical perfusion. Sodium, chloride, and to a lesser extent potassium are the main rapid, speedy regulators of intracellular pH. And clearly, if this changes rapidly, potentially there's an alteration in intracellular metabolic processes. But is balance better or not than unbalanced? Let's look at a few clinical studies. There were a lot initially of retrospective analyses. So this is from Andy Shaw and colleagues, a retrospective cohort study of more than 500,000 abdominal surgical patients, but this was taken from a claims, a financial database. And they found that there was a doubling in mortality in those given saline, more complications, more major infections, more renal failure. However, the vast majority of patients received saline. Only less than 1,000 received plasmolite, and there was an imbalance. Social status, emergency admissions, the hospital where it was given, etc. So again, this wasn't a matched prospective trial. And then the prospective trial started coming through. This was the split trial from Australasia. Over 2,000 patients randomized to either get normal saline or plasmolite in 4 intensive care units in New Zealand. There was no difference in mortality. A criticism of the trial is that in total, very small amounts relatively of fluid were given, on average about 2 liters either of plasmolite or saline. And crucially, and it seems rather crazy, that they didn't actually measure the plasma chloride. And so you wouldn't do a respiratory trial without knowing the gases. So it seems a bit perverse to do a saline versus plasmolite trial without knowing what the chloride level's doing. There's this nice infographic in anesthesiology that looks at some more recent trials. I won't go through them in any detail, but there was a SMART study from Matt Semler and colleagues from Vanderbilt, 15,000 plus patients in intensive care unit. There was no difference in mortality. They looked at major adverse kidney events at 30 days, and there was a slight difference, a 1% difference, which was statistically significant, but no other differences between the groups. From the same institution, Will Self and colleagues did the SALT-ED study, also in the New England Journal. And again, big study, over 13,000 patients, no difference in mortality, length of stay, and a bit of an increase, a 1% absolute increase in major adverse kidney events. A recent study's just come out from Maheshwari and colleagues, 8,000 plus patients, and no difference at all in outcomes, including no difference in renal, respiratory, or other complications. And this was intraoperative fluid. On average, about 2 liters were given again. So the pros and cons, I think hyperchloremia is often unrecognized as a cause for metabolic acidosis. So clinicians therefore just give even more chloride and cause more chloride overload. And so there is also a potential risk, I don't have the time now, in giving these chloride, in restricting chloride-rich fluids, but giving these hypotonic fluids to patients with hyponatremia, alkalemia, cerebral edema, and traumatic brain injury. Again, these haven't, to my knowledge, been subjected to prospective large studies. So is balance superior or not? It probably doesn't matter what you give if you're giving low volumes of fluid. It may possibly be relevant for large volumes. Potentially hypotonic balanced solutions may be potentially injurious in some situations like head injury. But my big secret, number one, is try to give the right amount of fluid, not too much, but not too little. And my second big secret is monitor what you're doing. Blood gas machines now routinely offer chloride levels. So therefore, if the chloride levels are going up and up and up, it's therefore not appropriate to keep giving more saline. I will finish there. Thank you very much indeed for listening.